Assalamu alaikum ji. This is Dr. Azhar. Good morning. I hope you're all well and your families are well as well. We are extremely busy nowadays because of this corona pandemic. Dental building is full of coronavirus patients. Very nasty disease, very, very nasty disease. Most of the patients get well though, but the minority of the patients who does get this severe disease, they don't do good. They die in front of your eyes, not able to help them. They get very, very hypoxic, very, very hypoxic. Once they get on the ventilators, game over. I mean, to be honest, game over even before ventilator when they get so hypoxic. So it's a lot of challenging in dealing with them. I know there's a lot of scary things about it. Doctors not willing to work. They're not willing to look after corona patients. Everyone has got its own reasons, but someone has to look after those patients. And I think it's our responsibility, despite of what happens, if we get it, if our family get it, but our first responsibility is towards our patients. And we have to take precautions as well, accordingly. Okay, I'm not going to bore you. So the nephrology has been started this week. And I think this is probably the fourth lecture of this week. I started with some sort of, or a third lecture. I started with some signs and symptoms and some investigations. And I gave you a CKD module. So I think next week is the last week probably for the nephrology. So I have got few slides to show you or to send you about the nephrology. Because of this online things, I have not been able to actually concentrate much on this. Historically, I used to teach all the topics of nephrology, so I go with my pace. We pick up the pace during our nephrology sessions in 2 weeks' time. But now the things are a bit different. So what I'm going to do is, despite whatever the topic for that day is, but I'm going to teach you a bit more, show you some more slides, so to give you some ideas. So I think I'm going to start with some sort of a learning module, just a taster again, and see what we can do about that. Should we read something? Should we read some maybe medical management of stones? Let's see if we can go through that. Okay. So what are the learning outcomes? You are having the screen. Your screen BMJ wali hai na? So you are having the screen. I've just confirmed about this. I mean, when in a free time, I actually tend to do these learning modules from time to time. It's a very good site, and it's very, very helpful, to be honest. Maybe a bit early for you guys, but once you get into the practical life, it will be much more. So I'm going to discuss about some bits about management of the renal stones. So first we'll discuss about the epidemiology of the renal stone, and then we'll see what are the risk factors for the stone formation. It is very, very common. So I find in my practice, and that probably 50% of the patients of nephrology, they attend the nephrology clinic because of the renal stones. And it's a bit of frustration as well. And the patients get bounced back and forth between the urologist and the nephrologist. So being a nephrologist, we probably like a medical management of the renal stone. The urologist, on the other hand, they would like a lithotripsy, or they would like some surgical procedures for renal stones. So it's a bit of sometimes end up in arguments Okay, after that we would listen to or we would read some sort of investigations which can help in the diagnosis of renal stones, and then we will work on the non-pharmacological management of the renal stone, and then the pharmacological management of the renal stone. Okay, so it is based on a standard practice in the United States, though. Let's resume. Right. Subscribe to BMJ Learning. So, sorry. Let me. I'm just trying to show you. So yearly is something that happens if this cock up now. Okay. Doesn't show me anything. So I don't need this. Browse. Renal stones. Okay. I think we probably are not going to be able to that thing, but let's see. Medical. Some modules need. See. No, it's actually not in the module, so I have to work on it though. Right. What else we can do? Uh, did you mean medical management of renal stones? Yes, I do mean medical management of renal stones. But no, it's just it's not giving me any joy. Okay. Maybe it's in the urology. No. Do you want to do this one? Okay, we'll do this one a bit. Okay. So resume module. Okay, so this module is about acute kidney injury, and so let's do some cases. So during a night shift on call, the emergency department refers a 64 years old man, Mr. D, a smoker who presented with shortness of breath. So someone who is a smoker presented with a shortness of breath, past medical history of hypertension, diabetes. So diabetes and hypertension are risk factors for what? For chronic kidney disease. His chest X-ray is abnormal, showing a patchy consolidation. So his shortness of breath was because of a pneumonia. He was recently treated for a community-acquired pneumonia. So after a community-acquired pneumonia treatment, this patient was presented with shortness of breath. You did some investigations. So patient saturations was quite low. He was anemic. CRP was high. And this patient has got abnormal creatinine and urea. Okay, and EGFR was. So you suspected an acute kidney injury, you don't have any previous results. Which two of the following are the most useful in confirming your provisional diagnosis of acute kidney injury? So what two things are helpful in diagnosing acute kidney injury? So previous by the renal function, if you have got a renal function in the past and there is a rise in the creatinine, it is an acute kidney injury. Okay. And what else? Measurement of calcium and phosphate levels. This can be low or high in both acute and chronic kidney injury. Medication history. Sometimes it can give you an idea whether you are CKD or not. Measurement of urine output, that will give you a diagnosis of acute kidney injury though, but that will not rule out chronic kidney disease. Renal ultrasound can give you a diagnosis of acute kidney injury, but this is partially correct. So let's view the answer. So acute kidney injury is very common. It's seen in 18% of hospital admissions. The two most important functions of the kidneys are filtration and water hemostasis, measured by urine generation. Okay. So urine output is a marker of the acute kidney injury. So filtration and water hemostasis. These are the key features in defining acute kidney injury. So when you define the acute kidney injury, what you are looking on creatinine and the urine output. So these two things, the fluctuation in these two things will define the acute kidney injury. Okay. So let's talk about a bit more functions of the kidneys. Okay, so we discussed two functions of the kidneys, filtration and water hemostasis. Okay, so the kidneys are also involved in blood synthesis, calcium and phosphate regulation, right? So measurement of hemoglobin and phosphate can be abnormal. Now listen to it carefully. Measurement of hemoglobin and phosphate. So both AKI and CKD patients can be anemic and can have hyperphosphatemic. So these two things cannot give us any help in our diagnosis of acute kidney injury. Okay. So functions of the kidneys, filtration, homeostasis, blood synthesis, and some hormonal regulation, which cause calcium and phosphate regulation. So urine dipstick, second to the urine dipstick. So urine dipstick does not help us define AKI, but it's a vital in this. Urine dipstick is a vital investigations in all our nephrology patients. So urine dipstick, and urine dipstick. So we are so much interested in urine dipsticks because we can judge the abnormalities in the kidneys. So urine dipstick, if someone has got an albuminuria, they are more prone to have an acute kidney injury, but it does not tell us that the patient has got acute kidney injury or a chronic kidney injury, but it is very important. So if urine dipstick shows blood and protein, it means there is an intrinsic damage. There is a glomerular damage. And most of the intrinsic AKI patients have got blood and protein. So renal ultrasound is often needed to exclude obstruction and also shows signs of chronic kidney disease. What are the signs of chronic kidney disease on renal ultrasound? Cortical thinning. Cortex will get thin. Loss of demarcation between cortex and the medulla. So, however, AKI commonly occurs on the top of CKD, so you can't differentiate between CKD and AKI by doing an ultrasonograph. Medication history is the most vital component of the history and may identify the patients who are at risk of AKI. So certain medications which patients are taking for your diabetes and hypertension can cause acute kidney injury if these patients are unwell due to some other reasons. Some medications which can be nephrotoxic if the kidney functions are not good. These are renin-angiotensin drugs. These are angiotensin receptor blockers, NSAIDs, intravenous radiocontrast agents, and antibiotics. However, about the intravenous radiocontrast agents, now recent studies have shown that they do not cause acute kidney injury. So there is no nephropathy such as contrast nephropathy. I hope you are with me. Okay, I'm going to summarize this slide. So acute kidney injury happens in 13 to 18% of hospital admissions, very, very common. Functions of the kidneys: water hemostasis, maintain the urine output, filtration, measuring the serum creatinine, hormonal functions, calcium phosphate metabolism, blood synthesis. So what are the, let me ask questions for myself. So if I want to see what are the features which suggest acute kidney injury? Anemia or hyperphosphatemia? No, these can happen in both. Urine dipstick can suggest acute kidney injury? No, urine dipstick will only tell us that if it is acute kidney injury, it is because of intrinsic damage, if there's an abnormal protein and urine and blood. Renal ultrasound scan? No, it only shows rule out obstruction and it tells us about whether there's an element of CKD or not. Medication history, very important, tell us to identify the risk for AKI, but it does not help us in diagnosing AKI. So two things which help us in diagnosing AKI is a serum creatinine and urine output. So you review the chance in the emergency department known that Mr. D has been catheterized. He was catheterized at a residual volume of 100 mils. So his urine output in the last 3 hours was only 43 mils, so which probably is 10 mils an hour. So he had hospital attendance to check up for diabetes when his ACR was 32, which means probably he had a moderate proteinuria. His dipstick showed 1+ of protein, and his baseline creatinine was 110, and now it is above 300. He was taking ACE inhibitors and simvastatin. So what stage of AKI does Mr. D have? So now there will be a stages of AKI. We're going to find out the stages of AKI. So what information we have here, we don't know what the urine output. So we know the urine output, it is 43 mils of urine in last 3 hours. So it probably is around 10 mils an hour or 12 mils an hour. Creatinine is 3 times the baseline. So I will think it's AKI stage 3 because creatinine is more than 300 or 3 times the baseline and urine output is less. So that's the correct answer, but let's see review about the stages. So CKD acute kidney injury stage 3 is defined as a greater than 3-fold increase from baseline serum creatinine. Okay, if serum creatinine is 3 times more than baseline, or if you don't have a previous serum creatinine and the serum creatinine is more than 354 micromoles per liter, it's an CKI stage 3. So one very important tip which you do need to understand, okay? AKI is not a diagnosis. Acute kidney injury is not a diagnosis, it's a classification system, okay? Like chronic kidney disease is a classification system, it is not a diagnosis. I want to know more about staging of AKI. Let's go staging of AKI. So there are three different definitions. KDIGO, AKI, and rifle is very famous. Common factors in all of these definitions. Well, okay, before I forget, you can take, screenshots for these, or you can write it down. It's on the screen. You can find. So there has been several staging proposed for AKI, and all are similar, and they all are confusing. They all are difficult to remember, and they all are sort of overlooked as well, though. Okay, so common things in all these definitions. So a rise of 26 micromole of serum creatinine over 48 hours, a 50% rise in serum creatinine within the past 7 days, a fall in the urine production to 0.5 ml per kg per hour, 70 kg mils, 30 mils per hour for greater than 6 hours. Most commonly used classification is the KDIGO classifications, but rifle and AKI are also used. So stage 1, when the creatinine is more than 26 micromoles within 48 hours, or increase from 1.5 to 1.9. And urine output criteria is 0.5 mils, less than 0.5 mils for 6 consecutive hours. Stage 2 is when creatinine rises from 2 to 3 from baseline creatinine, and stage 3 when 3 more than 3. 0.5 mils for 12 hours and 0.3 mils for 24 hours. Or someone is needing for dialysis. These are the stage 3. So there are some new markers of AKI. There are like several biomarkers for predicting AKI. What these includes neutrophilic gelatinase associated lipocalin, NGAL, kidney injury module, interleukin 18, quite a few. So NGAL has been studied in cardiothoracic surgery, and the rise in NGAL is a post-operative. So this rise in NGAL is before the rise in the creatinine. Kidney injury molecule is also being investigated. And then there are metalloproteinases, type 1 and type 2. So these markers, people are working on it to actually predict the development of AKI. So still there is no kidney troponin. Let's do it this way, okay? Same clinical scenario. Third question, having identified stage 3 AKI, you suspected Mr. D's ramipril. You suspend Mr. D's ramipril, nephrotoxic medication. So one lesson is, then you suspect an AKI, you stop the nephrotoxic medication. In addition to continue for antibiotic, you also prescribe fluids. So you investigate the acute kidney injury and treat it. So you give IV fluids. You check the urine dipstick, which showed protein and blood with some glucose. So Mr. Left kidney and right kidney were similar in sizes, and there is slight reduction in the corticomegaly. So this patient does have got a chronic kidney disease, no obstruction or hydronephrosis. So after 14 hours in the hospital, his urea continues to rise with either serum creatinine, and potassium is now going up, and bicarbonate is down. His urine output is averaging 10 mils an hour. He was 80 kg weight. He should be 40 mils an hour. He was tachypnic, hypoxic, and hypertensive. So you do refer this patient to nephrology. That's the one thing you need to do. And patients have got crackles bilaterally. So patient's probably gone fluid overloaded. I think so. Because you've been giving fluids, patient there is no urine output, and it's all going into the lungs. Okay? So have a look on this. What would you think the second would be? You know it's a worsening creatinine and urea. Think. Intensive care, you don't have ABGs. Patient's blood pressure is okay. He's not that much tachypnic. I don't think so. He's aparaxial. Antibiotic change, he's not paraxial. His white cells were okay, so there is no role in changing the antibiotic. Is not going to alter the course of acute kidney injury. What? So probably this patient is fluid overloaded. You ask for a chest X-ray and you decrease the reduce of the fluid rates. So Mr. D should refer to the nephrology opinion. So he may need a dialysis. He may need some diuretics to offload him. So that will be discussed with the nephrologist. Okay. So he is worsening. So let's concentrate on some points. So you asked for a nephrology opinion. His worsening kidney function and signs consistent with the possible vasculitis because he had a pneumonia, games fluid overload, he's getting oligoanuric, he had active urinary sediments, rising blood pressure, decreasing in urine output. What is the cause? Is retaining fluid. To stop or reduce the IV fluids. If you give fluids and make patients iatrogenic, acute kidney injury is associated with increased risk of death. When to refer the nephrologist? Indication of dialysis. Stage 3 acute kidney injury when there is no clear cause of acute kidney injury, when AKI is not getting better, when patient previously known to have a CKD 4 or 5, or when there is a diagnosis of intrinsic renal disease. So our patient needs a referral to the nephrology, reduce the rate of intravenous fluids, they very well needed diuretics. Three criteria for referring patient to the nephrology services. So indication of renal replacement therapy, stage 3 AKI, by any classification if the patient has got a stage 3 AKI. AKI that is not improving with appropriate treatment. If the acute kidney injury is not getting any better. And there is no clear cause, when the cause is intrinsic renal disease or when the patient has got CKD 4 or 5. So difficult assessment, okay? So clinical assessment volume status is very difficult. In an anuric patient, intake of 1 liter of fluids will lead to a weight going appropriately of 1 kg. As such, the patient weight is the most accurate guide to fluid loss or gone. Blood pressure. Blood pressure typically rises in hypervolemic state. Oxygen saturation and respiratory rate. In hypervolemic patients, patient gets hypoxic and tachypnic. The objective markers are skin turgor, dry mucous membrane, jugular venous pressures. Sometimes JVP and carotids can be very confusing. So JVP, so how you come to know it's a jugular venous pulse? It fills from the above. You can obliterate it. It has biphasic wave pattern. It is non-pulsatile, and it is positional as well. Okay, question 4 regarding Mr. D. So nephrology came and they did all the screening. So screening for acute kidney injury. So renal immunology screen. Let's concentrate on renal immunology screen. Most of your answers in the exam will include the renal immunology screen. So renal immunology screen consists of anti-glomerular basement membrane antibodies, anti-neutrophilic and cytoplasmic antibodies, anti-nuclear, anti-double-stranded, C3, C4, serum immunoglobulins, electrophoresis, and rheumatoid factor. And sometimes you have to check CK as well. While you are waiting for the results from the admission chest X-ray, will report you raising the possibility of volume loss on the right-hand side. So chest X-ray was reported as a volume loss. So you do a staging CT thorax because he has been smoker. So risk of contrast. So contrast nephropathy, as I told you, things have changed now. So adequate hydration is important than the choice of fluid. Okay. So you adequately hydrate the patient. So NICE advises, NICE is a National Institute of Clinical Excellence in the UK. It gets certain guidelines. Someone whose eGFR is less than 30 or patient had a renal transplant. So what are the features which suggest the intrinsic kidney disease? Let's concentrate on this, the features which suggest the intrinsic kidney disease. So most of the cases of acute kidney injury are pre-renal. I would say 80%. So someone who has got a dipstick hematuria and proteinuria should always prompt you. These are called as active urinary sediments. Blood and protein is active urinary sediments, and these are called prompt renal histopathology. Symptoms which suggest vasculitis is a rash, synovitis, arthralgias, nasal crusting, nasal deformity, significant proteinuria, urine albumin creatinine ratio is above 70, which means more than 1 gram. Recent changes is medication, penicillin-based antibiotics, PPIs, and NSAIDs. They all can cause interstitial nephritis. Okay. Okay, so question number 5. So Mr. D is much improved after 48 hours. His immunology was negative. A CT scan has shown no evidence of malignancy. His creatinine has fallen and his urine output has increased. His oxygen requirement has fallen. Over the coming week, his kidney functions further improves, and prior to discharge, medication review his metformin was restarted, but not his ramipril. Which of the following two statements corrected regarding the long-term prognosis? As this was a pre-renal injury, he will eventually return to the baseline level of renal function. This is not true because this doesn't always happen. He is likely to have a short lifespan. He will have an increased risk of end-stage renal disease. He requires urgent follow-up in the nephrology clinic. The speed of his recovery from AKI is irrelevant to his long-term prognosis. Okay. So he had a stage 3 AKI. But not to this baseline. So he needs an urgent, okay. Whether he is likely to have a shorter lifespan. Will he have increased risk of end-stage renal disease? Probably yes. That's partially correct. So one answer is wrong. So he has a shorter lifespan. So patients who develop a severe AKI have got shorter lifespan. That's a learning point. So many patients, especially with the pre-existing, will not return to their baseline renal function. So not always that AKI is going to resolve fully. Many studies have shown that AKI episodes to be long-term risk factors for death. Patients in whom the AKI lasts for over a week has got twofold increased risk of death after discharge. AKI episodes are long-term risk factors for end-stage renal disease, even if the renal function recovers fully. So patients who have got a CKD and develop an AKI and resolve fully have got a 40% chances of developing end-stage renal disease, as compared to the patients who actually recover partially. They have got increased risk. Post-discharge monitoring is very important. However, this doesn't need to be with nephrology. This would depend on the level of residual kidney function. Many cases can be discussed with CKD register. Okay. So it's one case with the 5 stems we have covered acute kidney injury. Although your topic for today was renovascular disease, which I'm going to go through in 3-4 slides. It's not a big who-shoe. Okay. So post-discharge follow-up is very important. AKI causes decreased lifespan. AKI causes increased risk of end-stage renal disease. Oh, sorry. Let's do this back. I have to do this. So we finished with the acute kidney injury. Now let's change the slides to something else. New share. What should I do? That is this one. Okay, so this one is for the renal artery stenosis. We'll try to go through it quickly. Someone 73 male, chief complaint shortness of breath, vitals, past medical history, hyperlipidemia, and hypertension. I'm going to teach you renal vascular disease again. So forget about the topics with me. I'm going to teach you all the nephrology in the next week by going through different slides. So it's got a slightly raised serum creatinine, hypertension, dyslipidemia, smoker, 73 years male. So hypertension, lipidemia means the patient is arteriopath. Condition improves with IV diuretics, systolic pressure remains 170, MRI shows left renal ostial lesion. So renal artery stenosis left side. What should we further evaluate it? So treatment options, medical therapy, surgical therapy, angioplasty, areas of uncertainty, guidelines, so narrowing of one or both renal arteries or their branches. So causes are atherosclerosis, fibromuscular dysplasia. Other causes are rare, which are dissection of renal artery, vasculitis, thromboembolic disease, renal aneurysm, renal coarctation, extrinsic compression. So characteristic of atherosclerosis, the difference between atherosclerosis and fibromuscular dysplasia. So the cause of renal artery stenosis could be atherosclerosis, could be fibromuscular dysplasia, or could be other rare disorders. So atherosclerosis is known happens when the patient's age is more than 50 years. The location is mainly ostial or proximal. Fibromuscular is a younger female, and they are more responsive. Effective treatment for fibromuscular dysplasia, all consensus is balloon angioplasty. Atherosclerosis, there is no consensus. Atherosclerosis renal artery is stenosis in CKD is a 5.5%. It's quite high. So medical treatment is important. So what are the pathogenesis? So renal angiotensin system decreases the renal blood flow, increases the renin, which increases the angiotensin 2. So when the RAS is activated, it decreases the renal blood flow. Angiotensin 2 is a potent vasoconstrictor, causes hypertension and efferent arterial vasoconstriction, which maintains the eGFR. So if someone has got a renal artery stenosis, they have got an increased risk of developing a chronic kidney disease, a coronary artery disease, stroke, or peripheral vascular disease. So vessels in other organs are also abnormal. So these atherosclerosis in other vascular beds. Clinical clues. Onset of stage 2 hypertension after 50 years of age. Family history of hypertension. Hypertension with association with renal insufficiency. Renal function worsen with hypertension. Repeat hospital admissions with heart failures. Drug-resistant hypertension. So all are clues towards something is wrong with renal arteries. So what are the diagnostic tests we use for the renal artery stenosis? Once you do suspect, you do a duplex ultrasound, which is non-invasive, skill observer leads, which is a bowel gas or a obese patient. It's difficult to do. MR angiogram or CT angiogram. So basically angiograms. So duplex ultrasound, excellent tool. Limitations. MRI, again, there's some limitations. Some scariness of contrast. MRI can cause nephrogenic systemic fibrosis, which is associated with the gadolinium nephropathy. So MRI scan, they use gadolinium. So gadolinium can cause systemic fibrosis, nephrogenic systemic fibrosis. So this is a right renal artery. This is an angiogram done. and that's the left one. So that's the left one, that's the right one. So both are, if you see, there's a filling defect. Digital subtraction angiograph. So they use smaller amount of contrast. So this is actually an angiography of the renal system. So functional significance of the lesion is very important to see the response of the revascularization. So treatment options, medical therapy, surgical therapy. Treatment improves the survival, improves the blood pressure control. Why do we treat it? We treat it because to increase the survival and increase the blood pressure control and less impairment of the renal function. So medical therapy, as I told you before, RAS, what does RAS does? If you block these two, multi-drug regime for blood pressure control, RAS inhibitor is recommended in most patients. So ACE inhibitors you still do give in renal artery stenosis. So what does they do? Effects of ACE inhibitors is they abolish the hypertension. If someone has got bilateral renal artery stenosis, someone has got bilateral renal artery stenosis, if you use the RAS, that will cause acute kidney injury because the eGFR dropped in both kidneys. Medical therapy. You do ACE inhibitor, which reduces the death. Statin, which reduces the severity of the renal artery stenosis. Antiplatelet therapy. So aspirin, statins, ACE inhibitors. And then is the surgical therapy. DME से मुझे next week का schedule ला दें. Dr. Azhar, final year. So surgical revascularization. Balloon angioplasty versus surgery, so there were similar rates. So non-surgical revascularization is always the first approach. So angioplasty and stenting. So you do a balloon angioplasty and then you can put some stent in as well. So this bleeding appearances is a fibromuscular dysplasia. And this one is atherosclerotic lesion. So there's a fibromuscular dysplasia, you do a balloon angioplasty. In atherosclerotic renal disease, which is like this, balloon angioplasty is less effective. And there are certain indications to do angioplasty and stenting in atherosclerotic disease lesions. Predictors of favorable outcome of angioplasty: age is less than 40, hypertension is less than 5 years, and blood pressure systolic is less than 160. So these are the predictors of a favorable outcome. Stents limits the elastic recoil, so they always have got an additional benefit over just angioplasty. So there are recent trials happens, Astral trials. So revascularization, when you do a revascularization, so renin angiotensin aldosterone system will go down, sympathetic nervous system will go down, which controls the blood pressure, which improves the survival, and which causes less impairment of the renal therapy. If you do a medical therapy and direct at the same pathways, it gives the similar benefits. So angioplasty and stenting versus medical treatment alone, no one knows. No significant benefit from revascularization in recent trials. When you have previous algorithm, so clinical finding associated with renal artery stenosis absent, done. If it is present, you do a non-invasive imaging first. A renal artery stenosis is present, so you check for which area. Unilateral artery stenosis and asymmetric perfusion pressure, you consider revascularization. Bilateral renal artery stenosis, you consider revascularization. Unilateral renal stenosis and symmetric perfusion present, you follow them clinically, you don't do anything. So revascularization recommendations, who need revascularization recommendation? Congestive heart failure and pulmonary edema. So if patients is developing a heart problems or a pulmonary edema, they need a re-evaluation. Okay, so that's a bit about renal artery stenosis. So we're going to meet next time. I'm going to leave you now. I'm going to finish off the lecture. Okay, thank you.